we will, I think we will start. We still in colitis, of course, بس أنا في slides today, you can see that I added this sentence, pouchitis and caphitis, which is an area that I think a lot of us find it difficult. Is that correct? Do you find the pouchitis easy or difficult? Can anyone, or if you would like to write on the chat room, please just let me know what's your feeling about this area of pouchitis. And okay, it's good. If this is the first time you hear it, that's not bad. But for those who have heard about it before, just tell me what's your feeling? Do you find this area easy or difficult? So if you just would like to share your views on the chat room, that would be nice. Okay, so Dr. Iman added it is difficult. Right, so it is going to, in the second part of the lecture, I'm going to stress a little bit on this area عشان خاطر تبقى واضحة للجميع, and hopefully it will make life easy. Of course, what we've discussed before, that we discussed all of this في الأربع محاضرات اللي فاتت, and we said how we can identify each and every features and how much weight it does carry overall in order to reach a diagnosis. And what we try to do is to avoid the diagnosis of non-specific inflammation لكل الأسباب اللي اتكلمنا فيها في المرات اللي فاتت. And we've paid a lot of attention to the crypt architectural distortion, and we said what it stands for, and each of these symptoms we did discuss in details, how you recognize it and how you can see it, and all of that in order to be able to put the stamp of chronicity on the case. And then we started to search for other diagnostic clues, and we spent a good time looking into other diagnostic clues, especially of inflammation, like neutrophils and how they behave, like basal plasmocytosis and how that behave, والcolitis والpatchy والfocal inflammations وكل الحاجات اللي اتكلمنا فيها في المرات اللي فاتت. وقلنا على سبيل المثال للحصر هو ان مثلا روجر فيكنز في الكتاب بتاعه الاخير بتاع colonic biopsies, he said that yes, there are symptoms which can be very reliable or most reliable for the diagnosis of inflammatory bowel disease, and that does include, for example, basal plasmocytosis plus the architectural distortion, which tells you that there are some features will carry more or heavier weight than other features. And then we have visited the inflammatory process. وفي المحاضرة اللي فاتت اتكلمنا شوية عن الإديمة and how it can mask the inflammatory cells في آخر المحاضرة. وقلنا, for example, in Clostridia, difficile infection, what tends to happen that you get edema and that mask the inflammatory cell infected. لكن في نفس الوقت there are other conditions which you can see that the number of inflammatory cells are less, right? And so it is still come under the heading of colitis, like an inflammation, but it's an inflammation without cells. So how does that work, right? احنا definition بتاع أي inflammation, it has to have cells, inflammatory cells. So now we are confusing the picture a little bit by saying إن ممكن يكون في بعض subtypes من الكولايتس ما يكونش فيها inflammatory cells. يعني زي هنا مثلا, if you look into the site of these slides here, let me just mark with a pen. Actually, you can start counting the inflammatory cells, and you probably will be able to give me a number if you spend like a minute or so to count the inflammatory cells. That shouldn't be really the case, because you should not be able to have the luxury of being able to count how many inflammatory cells in one field. That shouldn't be the case. The other features which you probably can also see here, that this is the muscularis propria over here. And obviously you can see that the base of the crypt, it doesn't reach, right? It's not touching. And that's quite universal. So if we are to basically think of these features properly, then there is definitely a crypt shortening, which you are able to highlight, and you are able to see that most of the crypts feel slightly fatted. Yet this is the close-up just to show you the number of inflammatory cells, how they have decreased in number. But here you can see that most of this, or nearly all the crypts, they are not trying to touch or reach the muscularis mucosa. فبالتالي there is this universal pictures, which you call it crypt shortening, which is one of the features which you see it with the crypt atrophy. And the crypt atrophy in general, لو نفتكر مع بعض, we said that it can be, it is a sign that there was a crypt architectural distortion here, damaged the crypt, and when the crypt did regenerate, then they are not regenerating with the same height, and then you become having slightly less surface areas, or this crypt shortening, which is one of the features of the crypt atrophy. But overall, what does that tell you? Despite the fact that you don't see a lot of architectural distortion apart from the crypt atrophy, but this is enough to call it quiescent colitis if you have a patient known to have an ulcerative colitis or Crohn's disease before, then, and this was a follow-up biopsy, العيان ماشي على maintenance treatment, والعيان has been for a year or 2 or 3 on remission, so they just do the follow-up biopsies, and sometimes this is what you will get. So this is here is quite important into that context, and it tells us a lot of the story about what is happening. Let's move on. So this is another example or another case, and what you are able to see as well, okay, you might look into these inflammatory cells and say, well, I don't feel that the inflammatory cells has got a significant increase in inflammatory process. You see, like there is no increase in lymphoplasmacytic inflammatory cell infiltrate, and there isn't anything acute. The crypt looks fine, so we will keep looking into this. The surface slightly irregular. We can say that the surface looks slightly irregular, but the inflammatory cells looks okay. And here I just to show you the type of inflammatory cells toward the upper part, and toward the lower part, you don't have the clusters of plasma cells, hardly any plasma cells at the base of the crypt, to call it basal plasmocytosis. We discussed that. But look what you have. You have this. Any takers on what you have? What is this? Anyone? Just type on the... Exactly. Yes, so you have that, right? And let's take you back. It was there. It was there. It is here. It is there. But you can see that the inflammatory cells are not a lot, you see. So this is another example of how sometimes the inflammatory cell alone or the maintained gradients of the inflammatory cells can deceive you. That's definitely can deceive you, and you miss what might be on the surface just because simply you just focused so much on the inflammatory cell infiltrate, and you are not trying to address the other protocol of assessment. You start from the lumen, the surface, and then you find your way downwards. So this is also another example how you can miss something like this. And this is just a close-up. And of course, you don't you can use an immuno now for this. We don't tend to do the Wharton study because the lab, it's a very time consuming and very labor intensive, but there are special immuno. But this, so don't forget the lumen when we are talking about this. But the other concept which I find that it's important, of course, and every one of you does teach this concept بس للميديكال ستودنتس وكده، لكن الصعوبة هنا بتكون لما when you try to apply that concept on the biopsy, right? And for the junior doctors attending with us today, you need to get this right? You need to be able to know when you will use that terminology in your report, right? Because it is like in the renal pathology, when you use the word focal or diffuse, or when you use segmental and focal, you see they have a completely different meaning, isn't it? But here as well, in the biopsy world of the GI pathology, they have a completely different meaning, right? So anyone, can you just suggest when you will use patchy and when you will use focal? Anyone can tell us on the chat room what's your belief about, or do you think there is a difference when you describe the inflammation as patchy or when you describe it as focal? Do you think that there is a difference, that it might change how you will reach a diagnosis? Anyone? How you interpret the word patchy? So can you tell us how do you interpret this word patchy? Okay, so some people say multiple foci, separate patches, or solid, it's focal. Patchy with skip lesions, focal, when no inflammations between areas. Areas is a very soft word, isn't it? Yes? So area is a very soft word. Right, so I agree with you that patchy will have some skipping, but isn't focal also does have skipping? It does. But if you are to use the word focal, use it on the single biopsy, right? So if you are describing for me a one cecal biopsy and it has got one focus of inflammation within it, then just describe it on that single fragment, right? That you can see the whole fragment of the biopsy, but you only see one area within this biopsy that has got the inflammation. So in that case, use the word focal. That's absolutely fine, right? But the word patchy, it is when it has two situations here, the word patchy. The first situation that you have received, for example, let's say 6 biopsies from the sigmoid colon, 6 biopsy fragments from the sigmoid colon, and one of them has got the inflammation while the others don't, or 2 of them has got the inflammations while the other 4 don't. يعني انتم لازم تتخيلوا معايا هو السيرجن او الجاسترونترولوجيست لما كان بياخد ال6 او 7 بايوبسيز دول، هو مش واخدهم جنب بعض. السيجمويد كولون let's say it is about 25 centimeter roughly, for example. And if he is to take a sigmoid colon biopsies, he probably will take a biopsy every 2 centimeter in order to cover the entire surface area of the sigmoid colon. So in that case, yes, you can describe the inflammation as patchy, although it is all within the sigmoid colon, but there is 4 free and 2 of them has got the inflammation, then that's patchy, okay? Like in focal, if you have only one of the biopsy fragment of the 6 biopsies from the sigmoid colon that has got inflammation, then in that case I will choose the word focal instead of the word patchy, right? So this is another area. Of course, the other word for patchy will be that if you started to get a segmental infection, like for example, rectum is spared, and then ascending colon has got, and transverse colon has inflammation, and then cecum is spared, then you can for sure use the word patchy by all means. So, but remember the word focal, it is only when you describe the infection within the single biopsy. Is it diffuse or is it focal? But the word patchy is more, as some of you said, skipped lesion, but within the same area or within different areas, but you will need to get this right. You need to practice and train your mind to get it right, because there is a huge difference between this. So if you have, then you can say focal and patchy. Then if you can have the mix, Dr. Mai, you can have the mix between the two. There is nothing to stop that from happening. For example, in Crohn's disease, the classic way of describing it is going to be focal and patchy, right? Because that is the way it is. However, in some cases of diverticulitis, you might find the infection only patchy, right? Because not every diverticular is causing diverticulitis. Diverticulitis is a complication for diverticular disease. على فرضاً إن أنت عندك 70 أو 80 diverticuli في الsigmoid colon, and you received 6 or 7 sets of biopsies من الsigmoid colon, 1 or 2 of them are showing the inflammation, then it is patchy, and then it depends what's happening within that biopsy. Is it only 1 or 2 crypts? Then you can call it focal and patchy, or are there all the crypts are involved with the inflammation? Then you can call it more generalized infections, but segmental and patchy within the sigmoid colon, which goes more with the diverticular disease. And diverticular disease is a very skip type lesion when it comes to diverticulitis, for example. Okay, some diverticuli will look completely normal, while some others will look really inflamed. The same things can sometimes happen with mild infection with the drug-induced colitis, because you tend to have a patchy disease and focal as well. So it is not like it's not forbidden to use the two, but you need to tell me patchy means that you know that there is a segmental involvement, while focal, you know that within the area where it is inflamed, the disease is very focal, okay? Or the active inflammation that's present is very focal. So that will give us an idea and will organize the way of your thinking as well. So this is just you need to train and rehearse into this. And then we're still in the search for some other clues. And I just wanted to highlight that, yes, sometimes I don't give you the full pictures on the low power. Of course, I am limited the length when I take a picture. Lakin, I just want you to, even at low power, realize that if you have heterogeneity in your biopsies or not, okay? Like, do all these segments within this biopsy, do they all look the same or do they look different? So what's your views on this view, on this low power? What do you think? قولوا لي رأيكم. تفتكروا كلها شبه بعض من فوقها لتحتها من يسارها ليمينها ولا في اختلافات ما بين areas? Different. You are absolutely correct, right? So you can see that the areas which I just wanted you to remember this area here, which I wanted to highlight. Let me just use the marker pen. So let me see if I can draw. Are you able to see me drawing now on this? Can you see that drawing? Yes or no? Right. Let me just stop here for a second. Do you see the screen big or do you see it small? Because some of you said, okay, right, you should have said that from beginning. I don't know why nobody have volunteered. Let me try to see what's happening, what's wrong. 1 second. Can you see big or small now? Okay, good, right. So this area, for example, here, which I have just drawn on, this area is different. Another area here, which is just, I wanted you to remember this focus, which I have just put a circle around. And then the surface as well looks different. So if I look into this surface, the epithelium is intact and it looks okay. While if I look into this surface, the epithelium is not intact and it is falling apart. Can you see? It is falling apart. So you can kind of like figure out, okay, there is a problem here. There is a genuine problem. And this doesn't come under patchy or focal, by the way, but this is just a heterogenicity of the biopsy that's trying to tell you something, right? And this is how or what we will discuss in this particular case. Let me just see, because when I start drawing, my screen just hang up. Okay, so I will move now to the close-up of this. This is the one of the fragments that showed the biopsy looks okay on the surface. The crypt architecture is well maintained here, except in some fragments here at the base, where the crypt looks slightly, a little bit diseased, but overall, inflammatory cell infiltrate, not particularly increased or decreased in this area. They look okay. The gradient looks fine. So we are happy so far with that. Are we? Yes, except with that little area at the bottom. Now then, let's go to this other area that I have highlighted, and I showed you that the surface epithelium was lost. Now, if you look at the surface epithelium here, you can see that the surface epithelium is coming, it is falling apart. You can see it just a little bit here, still present, but here it's falling apart. This is not a preparation problem. This is not a heavy-handed someone on the microdebrider and he resulted in tearing the surface epithelium. You cannot assume that. This is genuine, right? And also, what we are able to see here is the fact that the lamina propria looks pink. Can you see how pink it is? دي زي ما يكونوا جبنا لون بينك ودهناها بيها. It's not this is not the right color for our lamina propria. And the lamina propria in general doesn't have a lot of collagen fibers, but here it is pink. It has got a little bit of more collagen, and you can see in between also there start to be a lot of red blood cell extravasation, which we can see, and here you can see some crypt bifurcations telling you that there is some regenerative changes happening. So all of these are part of the problem. And when I go to the edge to just show you how genuine this tearing of the epithelium, yes, definitely it is coming off. Definitely the lamina propria, especially in an area like here, it looks more collagenous stroma. And that's not right, because it's normally a loose type tissue rather than being a heavy duty type collagen like what we see. And here you can see the areas of hemorrhage and the red blood cell extravasation, which a lot of us oversee this because you might say el procedure can difficult, el endoscopy tears the mucosa, all of this can lead to hemorrhage, but we will keep looking. We will keep looking, and this is just another close-up on the mucosa to show you the, on the lamina propria to show you definitely it is pinkier than what you want it to be. And this is quite important. In terms of crypt itself, it is not particularly architecturally distorted in a big way. There is no basal cell, there is no basal plasmocytosis as we will be looking for that constantly. Now, I cannot see any acute inflammation into this field. So far, I am just looking with you here. This is the base of the crypt. Yes, maybe 1 or 2 plasma cells are trying to trickle down, but they are not clustering. They are not trying to cluster, and they are not trying to behave in any different way, except the fact that there is definitely a significant red blood extravasation there. Here and there, and here are the other areas at the bottom of the low power that I wanted you to see with me at a higher power. This area, this is the area where we discussed it briefly before. It will definitely look diseased. You see, ده زي واحد متغذي وواكل ومتربي على الغالي، ودوت معدوم ما فيش حيلته اللضا. يعني شايفين الجزئية ديت هنا هو وهي فعلا كده. يعني this is the right description. اوكي، لان المتربي على الغالي دوت ده يعني ايه، يعني ماشيه معاه كويس الحمد لله، والاشياء معدن والبلاد سبلاي داخل 100% يعني كل شهر. اوكي، لكن this person here at the side, this is really diseased, very collagenous in terms of stroma, and there is areas of red blood cell extravasation, hemorrhage. This is the weathered crypts. When I told you the weathered crypts are the unhealthy crypts that sit next to a healthy one, and I described it for you like a tubulitis اللي بنشوفها في renal pathology. tubulitis, you tend to have the lining, the cells become fainter and more diseased, irregular. They look very unhealthy. And this is what you get of that name, weathered crypt. And that tells you that there is, of course, an element. As soon as you see this weathering of crypts, you should think of ischemia, right? Because this is basically what tends to happen. You can see these cells are becoming degenerate, irregular nuclear outlines. Some of them start to have this faint nucleus, like as if it is disappearing. All of these are all degenerate features happening in these weathered crypts, and they are telling you that this is going to die, right? And the only reason why they will die because they don't have enough supply. There's no enough food. The salary ما بيخش أول كل شهر. فبالتالي you are dealing with ischemia. But a lot of other people, and we saw this area in the same biopsy at low power, that there is edema, but it was focal. You see, it wasn't the entire biopsy was edematous. It was very focal. And here, instead of the red blood cell extravasation that we saw before, we have a definite areas of lamina propria hemorrhage, right? And all of these together, when you put them, these are all features of ischemia. لما بنقرا في الكتب وفي البيبرز عن الاسكيميا, they always tell you ان هو it doesn't have a lot of inflammatory cells. And in these examples, you can see that, because in these examples, you see all the features that has been described in textbook. Yes, we saw some focal areas of weathered crypts. We saw that the inflammatory cells are not increased. We saw some epithelial loss for the surface. We saw some collagenous stroma. We saw edema. We saw hemorrhage with blood cell extravasation. All of these collectively, when we see them, they are all clues, but you cannot use one on its own. بما معناه أنا وريتكم المرة اللي فاتت إن كان في بعض ال examples with lamina propria edema مع infections, مع الكوليستريديا, مع E. coli, it can give you lamina propria edema. It doesn't necessarily mean that edema has to happen with ischemia. Edema can happen with a difficult procedure. We talked about that before, but here we have more. We have hemorrhage, we have widespread red blood extravasation, and we have the weathered crypt, we have surface epithelium falling. So all of these are ischemia. هي الصعوبة بتاعت الإسكيميا that when you see it in biopsy, if you don't think of it, بالذات في حد كبير في السن, you will miss it, right? You will definitely miss it. And I just wonder, I wanted you to just look again here. This is another example of this, and it shows you how the lamina propria can become more eosinophilic in some areas. Normally, lamina propria will not be that densely eosinophilic, and normally the epithelium should not be ripped off like this. ديت أكن حد جيب مشرط وقام ساحب الابيثيليوم, stripping it off. That stripping off of the epithelium is not a feature that I will take it lightly. Never, ever. I will never take that lightly, and just remember that, right? What I wanted to highlight into the cases of the ischemic colitis, I told you before that ischemic colitis can happen with a prolonged E. coli infections, can happen with Clostridia, but it also can happen with the thrombus, with the embolus. But this is just an example. I got it for you from one of our GI books to show you the medicine, the normal medication can cause a picture of ischemic colitis, right? Digitalis, vasopressors. Those can cause ischemia by causing some vasospasm in the smaller vessels, give you pictures of ischemia, right? الناس اللي هي بتعيش على اللي عندهم هاي فيفر وبيعيشوا على هم الديكونجستنت وبياخدوها حتى في التابلتس السودوفات والفلو تابلتس بيبقى فيها ديكونجستنت دايما فدول الافيدرينز والاذر components اللي هي بتعمل decongestions. This when it go to the bowel can cause as well some pictures of ischemic colitis and give you GI symptoms. You wouldn't expect, some of you wouldn't expect that we will put the non-steroidal as one of the mechanisms that it will cause, or one of the pictures that it will present itself as is ischemic colitis. Oral contraceptives, so all of those can cause ischemic colitis, and this is what we fall short, right? Like we احنا بنبص على الاريا of hemorrhage, الإديمة والstripping of epithelium ونقول it is all traumatic, procedure related. بس فعلا if it is coming with عيان عنده symptoms of colitis, do not ignore them. Just put the puzzles together and hopefully it will all pay off and it will be absolutely fine. So I just wanted to show you an example of the ischemic colitis just to highlight this. And while we are in this area of surface epithelium stripping, اللي شفناه في examples اللي فات, I just wanted you to show you that example as well. And my questions at this power is, I have two questions to you. The first thing, do you think the surface epithelium is stripped? Yes or no? The second question, do you think that the lamina propria is inflamed or not? Yes or no? So this is the two questions, right? So some of you said no, and some of you now saying yes, stripped. But what about the inflammation as well? Tell me about the inflammation. Do you think that there is an inflammation? Right, so some of you said yes, stripped, but no for inflammation. Some of you maybe focal inflammation. Okay, right, even at this low power, even at this low power, I just wanted to highlight or drag your eyes to some, right? I love low power, right? It's one of my favorite low power. Is when I look into, let me take them box by box, right? Because some of you are saying focal, right? Tell me about the gradient, okay? The gradient of inflammation. Is it getting heavier as you go down, or is it getting lighter as you are going down, right? Look at the gradient of the inflammation and tell me, right? Now apply the gradient for all the 4 fragments of biopsies. Here, there, and there. What do you think of the gradients? It's getting heavier, exactly, it is heavier. And that is the opposite of the norm, because a normal of the inflammatory cell, if you don't have inflammation, or even if you have a focal inflammation, that the inflammatory gradient will be maintained. So it will be heavier at top and lighter in the bottom. But what you have is the opposite, right? It is the opposite. If you don't look at this at low power and spend your time وتجيب كوباية الشاي وتجيب القهوة والبسكوت وتقعدي على low power 10 دقايق الأول to look and stare, you will miss this. And then you will say that you don't see a proper inflammation. For the second part, yes, I think the epithelium looks stripped in some part of the biopsies. And let's take that at a closer look. It's pink lamina propria. Yes, it is pink lamina propria. We agree with this. And I told you that this is not the right color of the lamina propria. You can see now the gradients properly. The gradients is reversed. it is getting heavier, which means that there is definitely chronic inflammation for increase in chronic inflammations for lamina propria. Like you can see here that this is very eosinophilic. Okay, so this is definitely very eosinophilic here and there, and then that should raise your eyebrow, because okay, it might, we know now with the eosinophilic lamina propria, can it be ischemia or can it be something else, right? So let's think. But I told you a minute ago, لو كنتوا لسه صاحيين معايا, we said that in ischemia you don't have increase in inflammatory cells, right? In chronic ischemia in general, you don't have increase in inflammatory cells. Like in here, you can see that definitely there is an increase in inflammatory cells, which is present throughout. Now, let's focus a little bit here into this area here and see what is happening. Okay, so there is an increase in inflammatory cells. Let's look at the number of lymphocytes. Do you see any increase in the number of lymphocytes? Yes or no? Within the epithelium? Anyone? Just have a look. What do you think? Any increase in the intraepithelial lymphocytes at all? Right, so some of you said yes, some of you said no. Okay, we will come back to this, but before I come back to this, I just wanted you to tell me what is the number of inflammatory cells, intraepithelial lymphocytes, that if you go above it, then there is an increase of intraepithelial lymphocytes. Do you have any number in your mind? Okay. Oh, 25 out of 30 is the diagnostic for lymphocytic colitis. But what I am telling you, I'm not telling you diagnose a lymphocytic colitis, right? I'm telling you, tell me the number that you will mention the word or the sentence of increase in intraepithelial lymphocytes, right? Exactly. Yes, Dr. Nada, Allah yaftah alayki. If you get more than 10 per 100 enterocytes, then you are in the area of increase in intraepithelial lymphocytes. And this is important when you read into these entities, especially in the microscopic colitis areas, that you need to know what, when we use the word increase in intraepithelial lymphocytes, or it is different from, this is diagnostic for lymphocytic colitis, for example, because diagnostic for lymphocytic colitis, yes, you need the 25, the 30, but let's say you have 15, right? So that 15 is only an increase in intraepithelial lymphocytes, but it is not diagnostic for lymphocytic colitis, yes? So just remember the difference in the terminology between the two. And I just skipping between the pictures here to show you that there is definitely an increase in inflammation, but there is also no proper basal cell plasmocytosis. It is just individual plasma cells. And there is a stripping of the epithelium on the surface. It is gone. Yes, it is falling. And here again, it is falling. And I'm just trying now to highlight into where the density of the pink, is it up or down? It is mainly up. And that is one clue that should make you able to think of what this may represent. The pink color, it is mainly present here in this zone. But when you go down, it is more of inflammatory cells, but without that pinkness, right? So there is, that pink is gone here, but that pink is gone, it's present here, and it is pushing the inflammatory cells away. So that is one thing that we need to focus on. Then I show you this area, which is everyone knows of it now. You are all able to give me the diagnosis based on that view, which is inside the biopsy, because this is the proper hyalinized area of collagen. Are we all able to see that? Yes. Okay. So you are all able now to tell me, okay, that is collagenous colitis. That's absolutely fine. Yes. So what I am trying to tell you now, that in the first glance, it was difficult to highlight that this is collagenous colitis because we didn't see that proper areas. It wasn't widely distributed. And collagenous colitis is focal and it is patchy, right? So if you are lucky, you might get it. If you are unlucky, you might not get it, right? عشان كده you cannot rule it out. لو مثلا السيرجن العيانة عندها watery diarrhea و70 سنة في سنها وكل الجاسترونترولوجيست حن عليكم ب one or two fragments of biopsy. You look at these two fragments, you cannot tell me microscopic colitis is excluded. You can tell me I didn't see features to diagnose microscopic colitis. Like you have to tell the surgeon that if you are after the diagnosis of collagenous colitis or microscopic colitis, he has to send you a lot of fragments من different segments, especially من الtransverse colon, and you because it is common to have it affected بالcollagenous colitis, and then you will be able to give the diagnosis quite well. We saw increased inflammation, yes. This case in particular, if I start counting, but I don't have the time, mainly in the surface epithelium, you will try to count. You will be able to see slightly the intraepithelial lymphocytes has increased. Like if I go into an areas like here and start to count the number of lymphocytes, I might find them like 13, 14, 15. Anything above 10 is usually means an increase in intraepithelial lymphocytes. But what the thing is, what is the difficulty for a case like this? And الريجسترارز دايما يجوا لي سعداء ومبسوطين ومهيصين ورافعين الاعلام. We found the case of collagenous colitis. ليه؟ عشان بس شافوا شويه pink stuff موجود تحت السب epithelial plane. بس and then انا اردهم خائبين في منتهى الحزن والأسى, only because before I diagnose or put a diagnosis of lymphocytic colitis or collagenous colitis as a microscopic colitis, the golden rule is that you have to have a chronic inflammation first in the lamina propria, right? So you have to have an increase in the lymphoplasmacytic inflammatory cell infiltrate in the lamina propria. Without that, you cannot diagnose that, right? So without this, it might be then amyloid, it might be something else, yes? Then without that, you cannot give me the diagnosis of collagenous colitis. Collagenous colitis is more of a diffuse inflammatory process, لكن الarea اللي هي بتشو you the thickened collagen, it is the area where it will reflect on the well-established disease, of course, like in lichen sclerosis, for example, for vulval biopsy, you don't tend to see the hyalinization in every case, but in a well-established case, you will see that. And yes, you cannot diagnose collagenous colitis without this, but you can suspect it because you have stripping of the epithelium, you have diffuse increase of lymphoplasmacytic inflammatory cell infiltrate. So even with a very focal subepithelial collagen 4 deposition, you can make it up and you can say highly suspicious for collagenous colitis. بس بشرط واللي أوله شرط أخو نور هو إن you have to know the history, okay? Because you can diagnose a collagenous colitis in a patient present with altered bowel habit, like constipation, diarrhea. You cannot diagnose it in a patient who's presented with constipation. You cannot diagnose it with a patient who's presented with PR bleeding, right? Then you will be overcalling. لأن الhistory is classic. الhistory is classic. You see, what tends to happen for these questions, what do we mean by the stripped epithelium? Is this epithelium shouldn't be stripping off, يعني coming out. زي ما شايفة السيجمنت of this epithelium المفروض إن هي كانت ده كان بيتها ومكانها ومطرحها وكانت مبسوطة وسعيدة هنا. لكن when you get this thickened layer of collagen, it tends to make a shortage of the blood supply, and the cohesive or the desmosomal power to attach this epithelium to the basement membrane will get stripped off, and then you get that stripping of epithelium, which basically it's a genuine. It is genuine, and it should catch your eyes when you see something like this. It doesn't happen quite often in a lot of diseases, but it happens now, as I showed you, in the ischemic colitis, and it also does happen في collagenous colitis, as we saw in this example. This is another more difficult example. These two pictures that I will show you, this is the case which has been shown recently in the John Hopkins tutorials that they do it, I think, every week or every couple of weeks. So they show this image and they said, because you have increase in the inflammatory cell infiltrate, you have a focal, very focal area of hyalinized collagen. You can see it just at the edge of the biopsy here. Sorry, where are, here, look. Can you see this area? You can see that there is thickening of this collagen. And this is when the measurement come handy. They say if it is above 10 micron, then this is a thickened collagen. Can you see how focal that can be? But can you see as well that the epithelium is stripped? It's coming off it, right? فبالتالي it is just telling you that even on a small biopsy, it's a very difficult example, this, right? But you can see that the 10 micron is like, the best way to describe it when you measure, if it can fit the 2 red blood cells, which will be 14 micron, then you are above the 10 micron, then you are in the area of diagnosing collagenous colitis. This is, but I agree with most of you. We will find an example like this a nightmare. This is difficult. We need to see more. We need to have the history to build up a case like this. And yes, if you count the lymphocytes on the surface epithelium, remember, we don't count in the crypt epithelium because naturally it is increased. But if you count it on the surface epithelium, you will definitely be able to reach this diagnosis. And before, because we started like 5 minutes late, I'll just spend with you 3 or 4 minutes just to discuss a definition. And then next time we will discuss this entity in more details, right? Because I was hoping that the time will allow us today, but it didn't. لكن الحمد لله على كل حال. So let's see this for the next. You see, this is an area which is very closely linked inflammatory bowel disease for a lot of reasons. But pouchitis and pouch-related changes are very difficult area in the GI biopsy, in GI pathology. And what I found out that when a senior consultants get these cases, he pass it to the most junior, deal with it. Or you will pass it to your fellows and registrars ومدرسين والمدرسين مساعدين, and then you will say, deal with it and give me a report. Yes, because it is very unsatisfactory areas, and it takes a lot of effort to understand. But what you need to understand when we are heading this pouchitis and pouch-related disorder, that Colitis, pre-pouch ileitis, and pouchitis they are all a spectrum of the same things. And you get a biopsy like this, right? So I will just show you an example, and I promise you we'll finish in 2 or 3 minutes because I know you have a lot of commitment. So I tell you, this is from a pouch, right? And this is the biopsy. And then you look at it, okay, inflamed, maybe, looks more lymphocytic in places, but the surface looks okay. And then another biopsy from a different areas, a gradient lost, so it looks inflamed. And then another biopsy close-up to show you, yes, the intensity of inflammation looks higher a little bit that you wanted it to be. Here again, not a lot of crypt architectural distortions, just the subtle angulated crypts. But here, another biopsy from the same patient, from the same area, showing you this horizontal alignment of the crypt. So there is definitely some mild architectural distortion present into this. You can see now that the gradient is lost in this biopsy. So you have increase in chronic inflammation. And that's the close-up on this biopsy to confirm what I have just said. What's your diagnosis in this case? Tell me, what do you think? That's it. That's what you have, right? And the sample is labeled as pouch biopsy. Give me a diagnosis now on the chat room. Pouchitis, okay. Any more? Chronic pouchitis, okay. Any more? Okay, so you're all going for inflammation. You are all labeling it as pouchitis. Based on what? Based on what I just said. That's completely and utterly nonsense, right? And this is what we will discuss next time. No, there is no dysplasia there, right? So don't go too far. I am not going to show you dysplasias in this slide. So don't panic about dysplasia for now, right? So this is not, and this is what we will be discussing next time, right? I will tell you why it is not, okay? I will tell you why a biopsy like this, you should let it go, okay? And you say, no, these features suggest chronicity, there's features this, there's features that, there's increased inflammation. No, I'm so sorry, okay? This is the only time where we will lie, بس دي كلها تكون كذبة بيضة. دي اللي هي كذبة بيضة. ليه؟ لأن this is the area where كل اللي احنا اتكلمنا فيه في ال5 محاضرات اللي فاتت, we will put it in the bag and we will say that rule doesn't apply. Everything I said, every word I said for the last 5 or 5.5 hours, it's not going to be applied in the area of this area. It has got its own rule and own way of how we will look at it, how we will diagnose it, and I will tell you how we will do that. But I won't have a lot of cases, but what I will have, I will make this area clear for all, and you will never ever be afraid from these biopsies. In actual fact, you will be able to write على باب المعمل أنا خبير الباوشايتس وخبير الكابيايتس. اوكي، واللي عنده حالة يبعتها لي. اوكي، اخليكم كلكم تحطوا لي يافطة ديت على المعمل. اوكي. I think we will have to stop لأن طبعا عندنا مشاغل وعندنا ارتباطات كلنا. والله يبارك فيكم. I hope that it was it made a lot of areas more clear. وإن شاء الله بإذن الله الأسبوع القادم we will discuss this area of pouchitis and colitis, and then we will know exactly how we will resolve this once for all. شكرا لكم كتير على تواجدكم معنا النهارده، والله يبارك فيكم جميعا ويزيدكم علم ويثبتوا في عقولكم ويثبتوا في قلوبكم وتفيدوا بناسكم واهاليكم. وزي ما دايما بوصيكم whatever you learn here please take it and teach it. And this is how we have been taught here in England. This is how we would like you to be taught as well. وإن شاء الله دايما ترجع بالنفع علينا جميعا إن شاء الله. شكرا لكم جميعا. I hope I always, Dr. Heba, I start from where I finish, so don't worry. Next time لو هتكوني معانا we will be able to, you will be able to understand it more إن شاء الله بإذن الله. فشكرا لكم جميعا ونشوفكم على خير إن شاء الله المرة القادمة. معلش إحنا مش هنفتح محاضرات yet، بس إن شاء الله when we launch the website soon after summer finish, you will be able to access المحاضرات على الويب-سايت and hopefully it will be يعني a better platform ليكم ويكون دايما راجع دايما بإفادة واستفادة. فشكرا لكم جميعا والسلام عليكم ورحمة الله وبركاته.